Good afternoon, Professor Vũ Đăng Liêu, Professor Võ Tuấn Đức, and colleagues. My name is Thương, and I am pleased to present a report on the topic, the value of magnetic resonance imaging with Primovist contrast in diagnosing liver and biliary lesion at Bạch Mai Hospital. And firstly, Primovist is a liver-specific magnetic resonance imaging contrast agent. This uptake mainly occurs via the organic anion transporter polypeptide OATP and is located at the sinusoidal membrane and biliary excretion via the multi-drug resistant associated protein MRP2 at the canalicular membrane. Because of the characteristics, the cells with OATP receptor will retain Primovist in the hepatobiliary phase, while transformed cells will show reduced signal in this phase. Thereby, we can evaluate the nature of the tumor cells. We have a sample of the hepatobiliary phase in MRI with Primovist. Firstly, differential diagnosis of incidental lesion. Secondly, evaluate for liver metastatic in patients with malignant disease. And thirdly, follow up the nodular lesion on chronic liver disease, especially early detection of hepatocellular carcinoma, and evaluation of liver function. And this is research result at Bạch Mai Hospital. A total 229 patients underwent Primovist MRI scan, in which it mainly used to differentiate FNH and adenoma. In this group, MRI with Primovist identified 110 cases as FNH based on increased enhancement in the hepatobiliary phase, combined with strong and homogeneous enhancement in the arterial phase. So I have a question. Why do we need to differentiate between FNH and adenoma? As we know, FNH is completely benign, so no further action is required. But with adenoma, this has potential for malignant transformation, so we need to follow up our surgery. Adenoma has 4 subtypes, so we need to find out subtype has potential for malignant transformation. Now I will talk a little about beta-catenin mutated HCA. This is a family of HCAs that share a mission mutation in the carine-associated protein beta-1 gene at exon 3 or exon 7 and 8. This mutation at exon 3 leads to strong pathway activation, and thus this beta-catenin mutated HCA subtype has high risk of HCC transformation. Most are azole or hyperintense during the hepatobiliary phase, corresponding to OATP overexpression. For example, one case in Bạch Mai Hospital, the male patient, 17 years old, no hepatitis or cirrhosis. The patient underwent the round thigh checkup and incidentally discovered a liver tumor. On CT scan, we can see a large mass with heterogeneous density, strong but uneven enhancement after injection, central necrosis, and persistent contrast in retention in the delayed phase. Beyond the characteristic, we can think of an adenoma lesion rather than FNH, but no washout on portal, venous, and equilibrium phase. In addition, it should be noted that the patient is a young male patient. And in MRI, this mass has heterogeneous signal on various pulse sequences. Primovist retained lesion in the hepatobiliary phase at 10 minutes and 30 minutes. The patient underwent surgery afterwards, and the pathological result was HCA with beta-catenin mutation. So I would say that with a suspicious adenoma lesion, especially with risk factor such as more often in men associated with male hormone administration, glycogen storage disease, and familial adenomatosis polyposis. We need to pay special attention to the beta-catenin mutation due to the high risk of malignant transformation. For patients with chronic liver disease, it's important to focus on detecting hepatocellular carcinoma lesion to help patients have timely treatment strategies. For example, a male patient, 58 years old, with hepatitis B and cirrhosis, on a MRI image show a nodule increased T2 signal, slightly decreased signal on alpha, and restricted diffusion. Strong contrast enhancement in arterial phase, but no washout in venous phase. This has no typical imaging feature of hepatocellular carcinoma, but in the hepatobiliary phase, this nodule has decreased signal compared to surrounding liver parenchyma. And result biopsy confirms this lesion is HCC. So, regarding the role of early diagnosis of HCC in patients with chronic hepatitis, metabolic and molecular alteration occur prior to morphological and vascular dynamic change. On dynamic CT or MRI, the kinetics may not yet be typical, but MRI with a hepatocyte-specific contrast agent already reveals the lesion. Another important goal of MRI with Primovist is that in a patient with primary extrahepatic malignancies presenting with liver nodules, secondary differential diagnosis is important. For example, on case a female patient 61 years old, no hepatitis and cirrhosis, but the patient has colon cancer treated with oxaliplatin chemotherapy. On CT scan, we can see the lesion hypodense pre-contract in anterior phase and venous phase. This lesion gradual enhancement from center to periphery, accompanied by dilation of the central lobular venous branch. On MRI, this lesion detected hypointense on T1, hypointense central on T2, slow central arterial phase enhancement, gradual periphery enhancement in venous phase. And hepatobiliary phase. No contrast accretion observed. Biopsy has confirmed this diagnosis is FNH. So I will talk a little about sinusoidal obstruction syndrome, about the mechanism. Toxic agent cause damage to the endothelial cell on the endothelial cell of the hepatic sinusoid, leading to loss of sinusoidal wall integrity, extravasation of red blood cell into the space of exit, and detachment of endothelial cells, resulting in interruption of the sinusoid and central hepatic detection. There are direct cause and indirect cause, and oxaliplatin is one of them. And liver injury caused by oxaliplatin has sinusoidal dilation, hepatic sinusoidal obstruction syndrome, and centrilobular fibrosis, hepatic congestion, and nodular regenerative hyperplasia in the liver. And this is my presentation. Thanks for the attention.